Okay, so welcome friends to this Tuesday academic program. Today we are discussing about again one more topic in the series of extracorporeal therapies. And this is again an area where there is a new interest. Most of us who are using a good volume of ECMO cases, we do see patients with acute respiratory hypoxemic failure. When we initiate them on a V-PA ECMO, some of our patients, due to many other reasons, including recirculation, high cardiac output state, increase LV afterload, and many reasons, we are not able to achieve the required oxygenation status, and we struggle to sedate them, paralyze them, take the things, drop their cardiac output by actually calming down them on all many things. And sometimes this acute ARDS induced right-sided heart failure is not uncommon, acute cardiopulmonary, and that leading to LV failure or LV dysfunction, needing some amount of, RV dysfunction, not needing a RV support. So in both the situations where we need some amount of RV bypass, so we may have a role to play over a VV ECMO to a Veno-Pulmonary Artery ECMO, where you drain from venous system, maybe RA or some of the draining systems from inferior vena cava or superior vena cava, and then directly actually passing it to a pulmonary artery. So which actually bypasses your right ventricle, and most of the times that's in the recent trends has shown to have some benefits in patients where we needed a right ventricular bypass, or those patients who are still having a problem with a recirculation or a high cardiac output state or having a air hunger. So during the recent times when I was a part of the recent ECMO Congress in Kolkata, Dr. Rodrigo Diaz happens to be a same faculty, and he was actually mentioning about how a V-PA, the Veno-Pulmonary Artery ECMO, can play a role in those situations, and his experience he was sharing. So I thought it will be a topic of interest for all of us who are using a ECMO as a regular therapy. So we tried to brought the topics. And to start this topic, we will have Dr. Sricharan, who is our ECMO physician and a part of heart and lung transplant unit in Yashoda Hospitals, Secunderabad, who will take us through a 10-15 minutes of the slides. Followed by, we will take expert opinion from none other than Dr. Rodrigo Diaz, who has a vast experience and knowledge in the field of ECMO, and particularly, I was looking at his works in Protect DO and V-PA ECMOs. He's the former chairman of ELSO LATAM chapter, and he's a part of San Joao de Diaz Hospital. So welcome, Dr. Rodrigo Diaz on board. It's a privilege and honor to have you on board. Thank you for being a part of it.
Thank you for the invitation. Do you hear me? Is that okay?
Yes.
Perfect. So just to let you know that I'm a cardiovascular anesthesiologist. I work in the cardiovascular ICU. I'm the chief of the cardiovascular ICU, and I run a program of ECMO in a private hospital and in a public hospital. I work in two places. So and between both centers, I've done so far this year 87 patients. So I hope to do a little bit more than 120 patients in both centers. This is a little picture of what we do in Chile. Last year we did 320 cases. Just to let you know what about Chile, so far away country from Europe. Reality is pretty different. And we are 19 million people. We're very few. So if you consider that number, you will see we do almost 2 ECMO cases per 100,000 inhabitants. So we are kind of between first cases in some countries in Latin America and first world countries. That's our ELSO endorsed course we do every year. Dr. Pranay is there working with us.
Yes.
You can see. So we have a connection with India. I was there 2024 with you, doctor, and this year, and I really appreciate it to learn from you a lot of things, and of course share our experience, as we have a lot of economical constraints that Americans don't. So we share kind of a lot of things. We have a lot of things in common. So.
Thank you.
First thing is V-PA ECMO involves drainage of deoxygenated blood from the venous system, typically the right atrium or central vein.
Dr. Rodrigo, we have a
Yes.
10 minutes brief presentation from Dr. Charan. Will we allow him to first do the presentation, then we'll come to you for your expert opinion?
Oh, perfect. I understand. Sorry. Okay.
So Charan, you can actually briefly present, and then we'll go to Dr. Rodrigo and Chile.
Okay, sorry for that.
Yeah. So we'll be briefly discussing about the Veno-Pulmonary Artery ECMO, how, when, and where. So the Veno-Pulmonary Artery extracorporeal membrane oxygenation, also called as the V-PA ECMO, is actually a VA ECMO, is actually a little modification of the venous part of the extracorporeal membrane oxygenation. So we will be actually reviewing the current evidence, applications, and probable future directions of V-PA ECMO in cardiopulmonary failures. So as that is being mentioned, Veno-Pulmonary Artery ECMO is designed to mitigate the right ventricular dysfunction. So any patient who is having severe ARDS can develop acute cardiopulmonary, or these patients who are having interstitial lung disease or COPD or these diseases who are having chronic hypoxemia or hypercarbia, these are known to have decrease in the pulmonary arterial pressures, leading to increase in the right ventricular afterload, and then probably many of these patients can go into actually RV dysfunction. So to mitigate this RV dysfunction, or to bypass this RV dysfunction, we can use what is known as a Veno-Pulmonary Artery ECMO, where there is a venous cannula where we drain from the right atrial or the IVC junction. But the reinfusion is, instead of in the superior vena cava or in the right atrium, as in VV ECMO, we will be reinfusing the oxygenated blood into the pulmonary artery. So this has advantages that you are essentially flooding the pulmonary artery with oxygenated blood, thus mitigating the hypoxic pulmonary vasoconstriction. You are also bypassing the RA and RV here. So thus the amount of blood from the RA is directly being bypassed into the PA, bypassing the RV. Hence, there is an amount of RV support which we can give. So actually, strictly speaking, if at all we can run this configuration with or without an oxygenator. If at all we are running this with an oxygenator, it's called V-PA ECMO. Or if we are running it without an oxygenator, it can actually function as a percutaneous right ventricular assist device, RVAD. Hence, V-PA ECMO can also be called an oxy-RVAD, where we are oxygenating the blood by simultaneously giving right ventricular support. So what are the differences between V-PA ECMO versus the other configurations? As I was telling you, the drainage is from the SVC or RA in case of V-PA ECMO. If at all we are using a single stage cannula, cannula with multi-stage, where we will be aspirating the blood from the RA and directly infusing the blood into the PA, like example like procedural cannula, which we will be discussing a bit later. The drainage is from the SVC or the RA. However, if we are using a bicaval technique, where we are actually using a single cannula for drainage and as well as another cannula for reinfusion, that's a bicaval technique. Here, we will be draining the blood from the IVC and we are reinfusing the blood obviously into the pulmonary artery. Whereas in venous ECMO, we typically in a dual cannula or a single cannula configuration, we will be draining the blood from the inferior vena cava or the superior vena cava and returning it into the RA. Hence, in case of a percutaneous RVAD, also the primary difference between V-PA ECMO and a percutaneous RVAD is that there is no gas exchange. We don't attach an oxygenator here. So in V-PA ECMO and percutaneous RVAD, we can see that the right ventricular bypass is done. However, as I was telling you, the difference is the oxygenator, whereas in venous ECMO, there is no right ventricular bypass. So we are completely reliant on the function of the right ventricle for an LV preload. So and the distinction that exists between V-PA ECMO and bicaval venous ECMO is that bicaval cannula have drainage from both vena cava with return directed to tricuspid valve. Like it does not actually give direct support to RV because The idea in a bicaval venous ECMO is to actually return the blood as close to the tricuspid valve as possible, so that majority of the blood reaches the RV. Hence we are essentially not bypassing the RV here, and hence we are not directly giving any RV support. So what are the clinical indications? The clinical indications of one Veno-Pulmonary Artery ECMO includes ARDS, or if a patient who develops RV dysfunction, which is quite common in ARDS patients because of severe pulmonary hypertension secondary to hypoxemia and hypercarbia. And also these ARDS patients are actually ventilated on a very high intensity mechanical ventilation, which can increase the RV afterload. Thus, there is a chance that the patient might develop significant amount of PAH and thus leading to RV dysfunction. In these patients, by providing an adequate RV support through V-PA configuration, we are also providing oxygenation, like in case of VV ECMO, and also providing RV support. The second most configuration, what we typically do is RV dysfunction after an LVAD placement. So RV dysfunction can happen in almost 9 to 42% of LVAD patients immediately after placement of an LVAD. Because when we are actually placing an LVAD, there is a significant increase in the venous return to the RV. And the RV dysfunction can get unmasked because of the placement of an LVAD. The second most common reason where an RV dysfunction can occur because of an LVAD placement is when the suction pressure is high, so that the septum is sucked in the direction of LV, thus causing architectural distortion in the right ventricle, thus causing decrease in the RV functionality and RV dysfunction. However, in patients who are in the immediate phase where we have placed an LVAD, because of the increase in venous return, if the RV needs to train for the increased venous return, we can actually place them on a temporary RVAD, and this temporary RVAD can be placed with the help of a V-PA. So we need not essentially, if at all the patient is having reasonably good pulmonary function, we can just use it as an RVAD. Or if the patient is having some degree of pulmonary dysfunction secondary to pulmonary edema, then in which case we can use it as an oxy RVAD, thus providing both the oxygenation as well as RV support. The third most important thing is a bridge to lung transplantation. As we will be discussing further, the V-PA ECMO configuration probably present direction shows that it is almost as much superior, if not more, or like it can be even more superior to venous ECMO as a bridge to lung transplantation, because it unloads the right ventricle and decreases the right ventricle wall stress. In patients in pulmonary embolism, especially the utilization of V-PA ECMO as an RV support in acute pulmonary embolism is a point of debate. It depends upon the presence of the clot. So if it is in a proximal clot burden, probably V-PA ECMO is not so feasible, because your clot is going to obstruct the cannula, or worst case scenario, your clot is going to get dislodged by the cannula. But if at all there is a partial distal disease, then in which case it can offer a partial RV bypass. So what we have to understand here is that if the patient is having a concomitant LV dysfunction due to any reason, in this scenario, V-PA ECMO is not going to be helping us more, because by placing a V-PA ECMO, we are essentially increasing or bypassing the RV and increasing the LV preload. And by increasing the LV preload, probably we are putting LV under more strain. So Veno-Pulmonary Artery ECMO, before initiating on a Veno-Pulmonary Artery ECMO, please always understand that to rule out LV dysfunction in these patients. So what are the potential benefits we can see with the Veno-Pulmonary Artery ECMO is the RV wall tension reduction. So it lowers the right ventricular wall tension, as I was telling you, by bypassing the RV, and it also achieves the ventilation and oxygenation goals. So it essentially by decreasing the carbon dioxide, increasing the oxygenation, as well as by bypassing the RV, it will decrease the RV afterload, and at the same time it lowers the right ventricular wall tension. The venous decongestion occurs by lowering the right-sided pressures and augmenting it can augment venous decongestion, improving the organ perfusion in patients who are having significant RV dysfunction. The chances of recirculation are not there when we are actually dealing with V-PA configuration instead of a veno-venous configuration, where in veno-venous configuration we always have the chance of or some risk of recirculation, whereas in V-PA it is not there. And if at all we are using the single cannula approach through the jugular, like multi-caval cannula, so dual lumen single cannula strategies, we can actually avoid a femoral access site, and it can facilitate rehabilitation. However, in patients who are also had placed on bicaval configuration with a femoral venous configuration, as well as a VP, like a pulmonary artery cannulation with a single stage cannula, it is not an absolute contraindication for mobilization. We can still even attempt mobilization. So studies have shown improved renal and hepatic function in patients supported with V-PA ECMO compared to conventional mechanical ventilation alone by decompressing or unloading the RV. So what are the risks and complications. The risks obviously are procedural risks where we are actually dealing with the bleeding, injury to the cava, injury to the right atrium, tricuspid valve, and right ventricle can occur because we are actually essentially giving a lot of large vein, large cannula into the right atrium through the tricuspid valve, through the RV, and it has to take the curve into the pulmonary artery. That is the reason we have to place a V-PA cannula almost always under direct vision, including like we can use a fluoroscopy or we can use a transesophageal echocardiography. So both of them has to be used. So what are the other operational complications? So because of the placement of a larger cannula into the PA, anatomically speaking, sometimes there might be some extrinsic compression of the right coronary artery, which is a rare complication. SVC syndrome can occur. Hemodynamically significant pulmonic wall regurgitation can occur because of the injury of the wall with the cannula. So if there is malposition, there is hemorrhage risk. And if at all we are running V-PA ECMO with significantly high flows, we also have to understand the position of the pulmonary artery cannula. The pulmonary artery cannula should be in the main pulmonary artery, or if it is advanced too much and reaches one of the right RPA or the LPA, and if we are running the ECMO on full flows, we are essentially increasing the pulmonary blood flow to one particular lung, which can actually lead to hemorrhage risk or alveolar hemorrhage in those patients. Left ventricular distension and biventricular dysfunction can occur, as I was discussing before, because in biventricular dysfunction, by increasing the or bypassing the RV and by increasing the PA flow, we are essentially increasing the LV preload, and the LV can get significantly distended because of this configuration. So what are the various clinical evidence? You can actually see that as these evidences go, everything almost is more than 60% of survival in these patients. So I'll actually deal with show the various amount of studies. There are no randomized controlled trials or very good quality studies which can actually show head-to-head comparison with the V-PA ECMO with veno-venous ECMO in patients who are having either ARDS or in lung transplantation per se. But many of these are single center observational studies. But you actually see, if you see the single center observation studies, we can see that the liberation from V-PA ECMO, even in COVID-19 patients, especially in, we don't know the actual wave of these patients in which the patient was initially put on V-PA ECMO. We can say that the liberation is around 70 to 60 to 75%. Almost one study even showing as much as 80 to 83% of liberation from V-PA ECMO while initiated at the right time. So you can actually see that there is significant decrease in cardiovascular, hepatic, and renal adverse events. Like patients on V-PA ECMO were more likely to be discharged home, lesser incidence of acute kidney injury, So these are the studies which we are actually looking at, but most of them are observation single center studies. Those are not high quality, high evidence based studies actually. The other studies, if you actually look at RVAD after LVAD implantation and even to bridge to lung transplantation and pulmonary embolism cases, we can say that the liberation range is more than 75 to 90% in these patients. The bridge to lung transplantation, we can actually see that the liberation is 100% in one study, whereas in 75% in one more study. Whereas in pulmonary embolism and RV myocardial infarction, we can see that they are almost like 50 to 60% survival, which are very good percentages when it really comes to survival, given the seriousness of these conditions. So this was actually a study or a systematic review, and the outcome of Veno-Pulmonary extracorporeal life support in lung transplantation using protective cannulations. So they have actually said that 34 patients who were placed on V-PA ECMO as a bridge to lung transplantation were included in this meta-analysis. And then, despite the limited evidence available, it has become very promising for the management of end-stage lung disease. We can see that the duration of support was variable, ranging from 42 hours to 15 days. And bridge to transplant was achieved for 71 to 100%. Survival to hospital discharge was 90 to 100%. 1 year to 2 years survival is 80 to 75%, which are really good studies, really good outcomes when it really comes to patients who are having ECMO as a bridge to lung transplantation, because bridge to lung transplantation also has an equivocal risk of going of mortality risk actually. When between VV ECMO and V-PA ECMO, we don't have a head-on comparison in a randomized control trial, but the outcomes in this particular systematic review are quite promising. So what are the various available cannula options? The various available cannula options include protective cannula, any dual lumen cannula, or reverse cannulas. So we will be looking at these configurations where if on the left side, you can actually see that it's a dual lumen cannulation. So there is one cannula which is placed through the IVC into the RA, and there is another the return cannula after the oxygenator is placed into the pulmonary artery. If you see the position in the pulmonary artery, it is in the main pulmonary artery just below the bifurcation of PA. Or you can actually go for what is known as this single cannula, dual lumen single cannula, where there is a port in the RA which is used for drainage, and this blood is returned back into the tip of the cannula, which is put in the PA, main pulmonary artery. So this is the configuration essentially of a protective cannula. So what are the various kind of like guided evidences we have? The guided evidences comes from echocardiographic guidance and as well as from the cath guidance, cath related guidance. The echocardiographic guidance you can actually see the cannula is sitting in the from the RV into the main pulmonary artery. So we can, this is the LA, this is the RV. And from the RV you can see the cannula in the RA is come into the RV, and from the RV you can go into the main pulmonary artery across the pulmonic valve. So proper position on V-PA ECMO is critical for successful support. So drain is being positioned at the right atrial caval junction. Return tip is ideally placed in the MPA. It either requires fluoroscopy or transesophageal echocardiography for guidance. So without guidance, we generally don't place these cannulas. And improper positioning can lead to hemorrhage when it is when the cannula is placed too deep into the pulmonary artery, where it is reaching the one of the branches of LPA or MPA. We can actually look for we can actually are looking at the risk of pulmonary hemorrhage. Or if the patient, if the cannula is getting dislodged into the RV, we are essentially not fulfilling the purpose of an RVAD. So what are the cath guidance steps we use? So after we actually, with the help of a sheath, we place the we place an 8 French or like 6 French sheath in the right internal jugular vein. From the sheath, we float a PA catheter, and after we float a PA catheter, we are placing a guide wire. So you can actually see the guide wire going from the internal jugular into the right pulmonary artery. So then on the guide wire, we are dilating. We are doing serial dilatations by Seldinger techniques, and after we are doing that, we are slowly cannulating the patient, and we are making sure that the tip of the cannula lies in the main pulmonary artery. So what is this VA-PA configuration? So sometimes it is like we can see that if the patient is having a venous drainage is from the right atrium, and the return is with a Y connector, where one Y is going into the arterial system and one Y is going into the PA system. VA-PA connection, it actually helps in the way that it can decrease the right atrial pressures. It increases the pulmonary artery, mean pulmonary artery pressures. Systolic blood pressure increases, LVEDP may increase. So we can actually say that theoretically speaking, it might look like a biventricular support, but the only disadvantage is that we are essentially increasing the LV afterload with the help of with an arterial cannula, and also increasing the LV input with the help of a PA cannula. So there is always a chance of increasing LVDP. However, if the patient is having adequate support, and then if your LV is getting distended, we can always use the PA configuration of this circuit for draining the blood along with the venous configuration, thus providing an adequate LV unloading technique. So it can be used in either directions. Sorry. So what are the various configurations in which we can actually essentially use this V-PA ECMO? So we can use a dual lumen cannula for a Veno-Pulmonary Artery. So DL stands for the dual lumen. So dual lumen Veno-Pulmonary configurations in both the scenarios. Or we can use a single lumen Veno-Pulmonary configurations where one cannula is in the RA and the other cannula is in the PA. Or we can actually use this dual lumen cannulas, one of the dual lumens of the dual lumen, either for drainage or for return. So if we can use both of them for return if you are wanting to oxygenate both the blood in the RA as well as in the PA, or we can drain the blood from the RA as well as in the venous system and give it back into the PA. It provides a much more efficient RV support. So the other combinations include the central Veno-Pulmonary Artery ECMO. The central Veno-Pulmonary Artery ECMO, as much as I have seen, we have actually managed a patient who is having an LVAD, who was instituted on an LVAD, and then to train the RV over the time, because as we have discussed, patients who are on LVAD, they can have an increase in the RV preload, and venous return increases to RV, so that can actually cause RV dysfunction. So anyway, they have opened and sternotomy was done for an LVAD placement. Most of these times they can actually go for a central Veno-Pulmonary Artery ECMO. We can actually see there are many other configurations which are available in this scenario, where in this first case, we are seeing that the cannulations are directly cannulated. So RA is directly cannulated and the PA is directly cannulated. In the second configuration, we can see that the RA is directly cannulated, whereas they have placed the graft to the PA, which is brought out, and then the cannula is pushed into the graft. The third configuration is where they put graft to both RA as well as PA, and both cannulas are connected to the grafts. The fourth configuration is where instead of RA, RV is cannulated, and there is a graft placement, or there is a direct cannulation of the pulmonary artery. So we have to identify and essentially identify the optimal patient subgroups in these patients. So who are going to be helped with a Veno-Pulmonary Artery ECMO, or in whose patients probably V-PA ECMO is better than a VV ECMO. So we don't have any head-on comparisons, but we should see that I would be really happy if at all we will be getting an adequate evidence on what are the best subset of patients in whom Veno-Pulmonary Artery ECMO is going to help more than Veno-venous ECMO support. So what is the optimal timing of institution of a V-PA ECMO has to be that. As we all know, ECMO should be instituted as early as possible, but at the same time, look at the optimal timing. So as I was telling you, there are no randomized control trials which have shown adequate or superiority of V-PA ECMO across compared to other RVADs or compared to other venous ECMO configurations. So if at all we have a very good evidence or robust evidence in this direction, we can actually formulate more robust guidelines. So in conclusion, V-PA ECMO is a promising form of extracorporeal life support with right ventricular dysfunction and impaired gas exchange. So it can do both. It can provide an RVAD. It can be working as an RVAD, or it can be used as an impaired gas exchange. While the current evidence is limited, but it may confer benefits to systemic decongestion and potential mortality improvement in select populations, as we have seen in some single center observational studies. Thank you.
Thank you, Charan, for bringing that overview. I think you brought that topic alive with clear explaining things. We have few questions. Over to you, Dr. Rodrigo Diaz. I think we wanted to hear from you, your experience and your take on the role of V-PA ECMO in current era of extracorporeal therapy. Over to you, Dr. Rodrigo.
It was a very complete lecture from Dr. Goda, and I appreciate it. Basically, I can show you what are the main indications we're doing right now in Latin America. I did a survey.
Please, you want to share some slides?
Yeah, I will show you some data on
it. No problem. Please go ahead.
Thank you. So I'm going to look at it. So I asked my different teams in Latin America, when do you use V-PA? We have a shot like you in India, and we will understand that some patients will move to V-PA because of low oxygenation or high recirculation. You go into V-PA and you will notice immediately a reduction in air hunger.
Yes.
So most of them are now going into V-PA because of this permanent air hunger when you have the patient in ECMO awake. So you see here, the 18 of them answered. You could answer different items in the same question, and almost half of them have never done V-PA. But when they do V-PA, most of them are because of right ventricular failure during VV ECMO. But the other ones are because of persistent oxygenation problem or persistent air hunger. And there's a publication from a Colombia work team from Bucaramanga that shows that oxygenation improves a lot after going into VPA. I just want to show you some things that give a point about complications. First, I really recommend always do it on fluoro. I mean, TEE is not that reliable. I mean, it's a tool. It's okay. It's better than nothing. But really, the gold standard is fluoro because you're gonna have a lot of kinking of your guide wires, and you really need to push a little bit the guide wire when you are advancing the cannula. I'm going to show you that, but it's a really big point. I would really suggest go to fluoro. Don't take risk because it's a high risk procedure. You're going to see here. I'm going to show you. You can have right-sided infected endocarditis, PA or right ventricular puncture, a rupture. You say that's theoretical? No, it's not theoretical. I mean, quite a few patients have done a tamponade after putting this cannula. So it's a troublesome procedure. You can have thrombosis. right coronary artery compression, I'm going to show you a picture of that. Of course, you can have severe vena cava syndrome if you put a very large cannula. You're going to see here the patients that was on V-PA. This was really intended to be a drainage cannula, so it was more like installed as a vent for a patient who had a huge VSD after an
Sir, we are not able to see your slides.
So are you projecting any slides, sir?
Sorry? Yeah, I'm projecting slides.
I'm not able to see, sir.
Do you see them?
Share.
No? Oh, I'm sure. Sorry, maybe it's my mistake. I'm gonna do that again. Okay, so do you see? Now you see it?
Yes, it started screening.
Yeah. So
yeah.
So what you're seeing there is a cannula in the right side, in the right ventricle. So it's the same installation that the V-PA. It's the same cannula. It's the same procedure. Just it was being put as a vent, but you can have exactly the same thing with the V-PA cannulation. I don't want to scare you, but this can happen. So always be very. I mean, have fear. I mean, it's not a simple procedure. Other publication just said that you can compress right ventricular, right coronary artery. So you have to look at right ventricular function right after putting this V-PA, because you can't have this compression and you just pull a little bit the cannula out and you will have the problem away. But remember, I'm gonna, Dr. Rahman, I'm gonna send you the video of the rupture of the right ventricle. It's so amazing, that picture that tells you very easily that this is not an easy procedure. Then you can have thrombosis. That's not a big deal. I mean, that's easy to resolve, but you can have problems. The other thing is that you can have alveolar hemorrhage or pulmonary hemorrhage because of the pulmonary hypertension and going with a lot of flow into the pulmonary artery. If you have pulmonary hypertension, always go from low flows to an increasing slowly. And you must start with 1.5 to 2 liters per minute and then go up slowly, because your patient can do alveolar hemorrhage with this new flow going into the capillary, into the pulmonary capillary bed. So these pictures is going to show you how to do it. You can put a swan guns first. I used to do it that way some years ago, but I think it's much more cumbersome than doing it this way. This is much easier to put a multi-purpose catheter with the gut wire going into the right ventricle. It's much easier. I've seen it. I mean, it's so, and you don't have to change from 0.025 to 0.035 gut wire, so that you don't have to change the diameter of the gut wire, and that's a big deal when you are working with the cannula. So you go with the multi-purpose and go with the normal gut wire into the right ventricle, and then it's pretty easy to go into the pulmonary artery. You just go flowing and floating with your multi-purpose catheter and with the gut wire, and then you go with the gut wire, the normal gut wire, and the multi-purpose catheter like you see in this picture. Then you leave there the multi-purpose catheter, take out the gut wire, and then you advance a stiff gut wire. It must be stiff, because if not, the perforation of the right ventricle is going to be much easier. You have to be careful with not perforating the lung, but usually these gut wires are soft in the first centimeter. So you just push it a little bit farther than the mediastinum, than proximal to the mediastinum. It has to be a little bit to the borders of the pulmonary bed, as you're seeing here. So once you have the stiff gut wire, you pull out the multi-purpose catheter, and then you go dilatating, and then you go with the cannula. Okay, look at that. That's a very scary situation. You go with the cannula and then it bends a little bit, and you don't want that. So if you try a couple times with your cannula and it doesn't work, go with a smaller French cannula. Don't try with the 21 or 23. If you're doing with a 21 or 23, it's okay. But if that's this movement in the right ventricle, just change it, and a 17, 19 cannula is going to go through right away, and it's much easier, and your patient is not going to have a problem. So that's the way you put the cannula into the circulation, and then you get out the guide wire. So I'm going to show you a patient who was on V-PA. He is a patient of 200 kilos, BMI of I don't know, 67, I think it was she. And she was always recirculating. We had two circuits at the same time for a while. Then when we changed to V-PA, we could just take one circuit, and the patient improved a lot. His air breathing, a lot. So imagine these 200 patients being moved with a wave ECMO with the normal VV. It's impossible. I mean, there's no way. So with the V-PA, you can really push a little bit farther the quality of your oxygenation. Usually, the patient tolerates 88, 87, but you can notice when you're moving your patient that this small increase in oxygenation of your V-PA is very helpful. Yeah. Just to show you the cannulas we use, and this is a picture of my last patient last week, and you just leave the cannula there. This patient, I changed him because he was always on 86, 87 sats. I don't mind really if the patient tolerates it, but he was very delirious, and we changed him to V-PA and really changed the hunger right away. While you are changing to V-PA, from VV to V-PA, you have to put a temporary cannula. So you see here a left subclavian cannula to support the patient while you're doing this thing. So in this case, I had the patient with VV, normal ECMO, and I changed first. I put the subclavian vein, then put the patient on subclavian femoral support, then I clamp the cannula and puncture the cannula, and then went with my guide wires through the right vein, right jugular vein. So everything is feasible, but always remember that your patient will not usually tolerate a lot of time with your being out of ECMO. And I just want to show you a last picture that show you how the recirculation decreases after V-PA, and this is very easy to show you. Let me look at it. Okay, so this is a patient who was on VV ECMO. Okay, you're gonna see I have a recirculation of 30%. It's quite high.
We are not able to see any videos.
Oh, sorry. I'm gonna share again. Now you see it again? Now you see it?
Yes.
Okay, so you're gonna see this patient has a 30% recirculation rate. I got this ELSA, I love it. And I use it in my public hospital. I have this device. So it shows you how much recirculation you have. And it shows you how much thrombosis you have in your oxygenator. So I changed this patient to V-PA, and then you see this is the same patient. You see your recirculation is 0, obviously. I mean, it's but that little change in some patients, not in all, just selected patients, is going to make a big change. So again, your usual or our usual way to do VV ECMO is just relax and tolerate 82, 85, 87% SATs. I don't mind. I listen to Dr. Palmer and I go to drink a coffee. But if your patient doesn't tolerate it because you want to move the patients, because even being in the bed, the patient is with this hunger, you're going to see a difference when you change to V-PA. Or if you have a high recirculation rate and you cannot fix it, just think of V-PA. Do you have to do it with single or dual cannula lumen? There's some small data that shows you that single lumen cannula is better than two cannulas, but it's much more expensive. It's much more difficult to get the device. And I really do it almost all the time with two cannulas. And I really haven't seen, I don't think there's a big difference if you do it, as I told you, I mean, with fluoro, being respectful about the difficulty of the procedure. It's not really difficult. It's just take care about when you go into the right ventricle. The passage through the right ventricle is a big deal, because tamponade is something usual in the different publications. So, and as I told you, I had one. But I had one with a huge right ventricular rupture. That's all. I think if there's any question or thing I can share with you, thank you.
Okay, so I think many of us were using, there are some questions which we'll take. There are points related to that this has been used in acute pulmonary thromboembolism. So the doubt is, if I have a block or occlusion with a thrombus in the pulmonary trunk or a main trunk or a saddle thrombus, how this V-PA ECMO is going to help? Will not that the thrombus cause resistance to the flow?
Yeah, doctor, I saw that data. I've never used it in pulmonary embolism. I do ECMO in pulmonary embolism. I love VA ECMO for pulmonary embolism. I think it's a great physiological way to approach refractory shock in pulmonary embolism. But the theoretical advantage of this approach is that you don't have to get into an artery, and I think that sounds nice. I mean, I have never done it, but the thing that I don't think is very easy is that if you're gonna go into the pulmonary artery circulation, you are gonna have the thrombus, as you say, after the cannula. So you're gonna have flow in some places of the lung, and in some other places you have high flow. So I don't think that's a good idea. Second, the speed with you put a VA ECMO is 18 minutes or 12 minutes in some instances if you are working in ECPR. So doing a VV ECMO or a VPA ECMO takes some time, much more time, because you're gonna have to go to the cath lab. So I don't buy it very much, really. Maybe I will think about it, but I think it's sometimes you have really straight path to a solution for some diseases. In this case, VA ECMO for me is so simple, and it works so well in pulmonary embolism that I really, it will take me a while to change from that approach.
Okay, so you mentioned very specific 2 points, that recirculation not able to set by any of your other majors will be one of your priority indication to think about, and you repeatedly talking about air hunger, patient not tolerating the hypoxia. These are the 2 indications. How about the bypassing your RV when there is a need as a RV support, for a temporary RVAD kind of support? So where do you place its role there?
I think it's one of the most serious indications. It will work, of course. I've done the central V-PA ECMO many years ago, and it's a fantastic approach. But what I do is VAV. I mean, I think it's, again, so simple to do it. VAV ECMO, a VV ECMO, go to VA. You take exactly 8 minutes or less with one more cannula. So I really don't think I will change to that for a while, but maybe the data in the future will show us this is a better or worse approach. My approach, at least, is for right ventricular dysfunction during V-PA ECMO is going to VAD. First, the team is used to it and the people is used to it. So I think it's still, it's not established indication. But again, it's not an established indication for air hunger. So I cannot really defend my position. But what I can tell you really that you won't see in the literature for a while is that every team that does PPA, I ask them, does this decrease your air hunger if you were not looking for that? And they always tell me yes. It's incredible how you reduce your air hunger, and in that way you can reduce ceiling. So I think again this is very empirical. It's very in the beginnings, but I can tell you that when you have that kind of patients, you have awake and breathing really bad. Try it, and please tell me how you do, how it went.
Yeah, you spoke about the single lumen, a single cannula with a double lumen with Protect DO has been expensive deal, and that has been a concern for many of us in India and its availability. So the double two cannulas probably is the only way, even in Indian context. Dr. Charan, do you wanted to throw any lights in situations where you have a recirculation not getting solved? You wanted a double cannulas. What are the sizes you will use, and what problems you will face in that if I wanted a cannula to be in a VA?
So actually, in a patients who are like as sir was just saying, patients with refractory recirculation and all, we were trying to put a V-PA ECMO, but we actually the idea that we were trying for a Protect Duo, but it turned up to be way too expensive. But we don't have we haven't actually tried double like two single lumen cannulas, one in the VA and one in the PA. Actually, we have to try that secondly. So probably a sir was saying
What
because
were the ideal sizes, Dr. Rodrigo, when I use the two cannulas there? What sizes do you use?
I usually use for going into the pulmonary artery, I use 17 or 19 French cannula. And I would like to have always the Protect Solo that has just holes in the at the end of the cannula. But you don't always have those available. So if you don't have those, don't worry. Your biomedicals generation 2 cannulas are going to have some of their flow into the right ventricle. No problem. Your recirculation is going to be 0 again. But that wouldn't work for a right ventricular failure, maybe. So, but for recirculation or improving your oxygenation, that is going to work too. And that's very easy to get anywhere, Medtronic cannula, here at least in Latin America. So if you don't have Protect Solo, there's a Aeroset cannula that is much cheaper, that has just a hole at the end, and I think that's the best cannula you can choose. There used to be Meadows to cannulas that will have just one hole at the end, but they're not doing it anymore. So right now, I think the best choice would be to have that Aeroset cannula. If you have money, go for the Protect Solo, but it's much more expensive. Or if not, if you don't have money and you have to and you want to do it anyway, just do the regular cannula.
Okay. You also spoke about the dreaded, very scary complication, including ventricular septal defect, tamponade, and all that. But the most common things which you said is when we use such a returning flows to the PA, there can be a possibility of increasing the PA pressure, leading to some amount of maybe alveolar hemorrhage or congestion under the. So what is that percentage of complication you see in your?
What I have seen in my own,
yes,
the right ventricle rupture you saw there,
yeah,
and I haven't had any other ones. But in Latin America, the group that is doing most of the V-PA ECMO cases, they have done more than 60. They have had in 60 patients 5 tamponades. with no rupture, but
Alveolar
quite
hemorrhages, right? PH.
I have not seen it because I'm very aware that that can happen, and there are some data from Dr. Bermudez in Pennsylvania doing a V-PA ECMO. This was shown before COVID pandemic, and you could see that there was a alveolar hemorrhage after going high with the flow. So again, V-PA is a good choice for right ventricular dysfunction as long as you be aware that if you go up with the flow, especially if you go fast with the flow, you will have hemoptysis or alveolar hemorrhage. So you have to keep that in mind. It has been published. It is a possibility. Just be careful when you have pulmonary hypertension. It's not a contraindication. Just be careful with the flow. That's all.
Okay. There were actually reports of vena cava syndrome, superior vena cava obstruction and all. Is it a post-decannulation? Is that the possibility because of stenosis? What is the reason why post-decannulation? What are the reasons? SVC syndrome.
What's the reason? I've seen that just once in my life, a pulmonary superior vena cava syndrome. Not because of V-PA, but with a double lumen cannula, an avalon cannula at that time. It was a relatively small patient, and we put a 3-1 French avalon cannula. And the patient, yes, got occluded the superior vena cava. So we had to change and did a 2 cannulas access to that patient. But yes, it's feasible. I mean, superior vena cava is quite big, but if it's a small patient and you put a large cannula inside, can be a problem. And of course, if you do a Protect Duo cannula, those are big. I mean, big enough, and the patient is small. Yeah, you could have that. As I told you, I had it once in my life, but with a double lumen cannula for VVA.
Any changes you do for anticoagulation? Some questions are related to anticoagulation.
Not really. Normal BD anticoagulation. So the target is 45 to 55, unless the patient has a pulmonary embolism. That is not the indication that we're talking about now, but always called pulmonary embolism, I go up to 65 of APTT.
Dr. Rodrigo, there are questions. If I have a patient who lands in RV dysfunction in an ILD PH patient on a VV ECMO, should I switch to VAV or I will switch to VPA?
Right now, today, I think I will go for VPA. I mean,
which is a standard of care
today.
at point of time today.
Yeah. Because as I told you, I usually could go to VAV. It's very easy. It depends on the condition of the patient. Again, too, if the patient is too ill to be moved from the ICU, I would do a VAV. But right now, right today, after doing some VPAs and all of that, I like the idea of not going into the artery. You know, artery are cumbersome. If you can avoid it, that sounds attractive to me. So I wouldn't mind today going to a V-PA ECMO after that right ventricular dysfunction in an ECMO. Remember, Dr. Rahman, that lots of right ventricular dysfunctions are 3 weeks after ECMO support.
Yes.
Not all of them are after right away the ECMO support. Yes. Some of them are, okay, but really you cannot tell when you're going to have right ventricular dysfunction. Can be at any time during your support. That's the truth. I look at the data and it's amazing. Patient is doing okay, and the 3rd or 4th or 5th week of support, the patient goes down with his right ventricular function. So yes, it sounds, I think you are very right. Right now, knowing more about V-PA ECMO, going with the V-PA in that condition sounds very attractive to me.
So in Indian circumstances, we do have a limitation of a single cannulas with Protect Duo. And we have, at this point of time, suppose we wanted to actually do way to go about a V-PA, how do you suggest us to do? We don't have the availability of the cannula, the single.
Yeah.
So what will be the option in a cost-effective way? We have also a limitation for cost in India. So what can be the
Of
difference?
course. No, so sorry.
So what are the different options? Charan, you can add to that. How do I can actually go about a V-PA ECMO in a situation where I really wanted to go for a V-PA ECMO?
Yes, for us, it's an issue to the cost. So I can buy, could buy until 2 months ago a Protect Do. I could push in my hospital and do it. It wouldn't be a big deal. But I think it's immoral to charge almost $4,000 for a cannula. I think it's
Too much.
I think it's too much. So that's why I never went with Protect. Well, yes, I did a couple of Protect Duo, but right now there are two solutions though. First, there's a German cannula that is cheaper. I will send you the photo in the WhatsApp, so you have it. Eroset is doing a double lumen cannula too, and that's going to be cheaper than Protect Duo. But again, I think the easiest way is to, if you have a single hole cannula, that's the perfect thing to do. And they are available as Protect Solo, but again, Protect Solo is $1,800 here. So I don't use it very much. I have used it a couple times. And if that's not available, I use Miros, that is not available anymore. And then I go for, I'm asking right now, Eroset, that they have this kind of cannulas, and they're not very expensive. And again, if I don't have any of those available, I use just what I have. I mean, Mackay or Medtronic Generation 2. And they're not the best choice. I mean, they are multiple fenestration. They have multiple fenestrations. So if you have available Medtronic Generation 1, I think that's a very good choice because they're very cheap and they have just a small fraction of holes. It's not single hole, but it's like 4 or 5 centimeters. But Generation 2 biomedicals are multi-perforated. So I use them anyway if I don't have anything available. But again, we say here we're good poor people. I mean, we get along with scarcity. So I use whatever I have available sometimes in my hand. So
Okay.
We use single-use long cannulas for a fem-fem veno-venous ECMO. So probably the return cannula which we use for a fem-fem veno-venous ECMO can be used also for a V-PA. What do you say, sir?
Yeah, but sometimes if you have I don't use very much the fem-fem configuration, but I just don't like it. I mean, it's a good choice anyway. But if you have 2 cannulas draining, and if you think you're gonna have some issues with drainage, just leave them both draining. I mean, I think you can have the cannula into the right atrium and it's not gonna recirculate because you're going into the pulmonary artery. So I've done that a couple of times. I've left 2 cannulas draining. It doesn't matter because you're gonna have, again, your return is gonna be all into the BA or the right ventricle if it's multi-perforated. And in the right ventricle, you won't have recirculation either. So
Yes,
you can do that too.
Okay. Thank you, Dr. Rodrigo, for that information experience shared with us. We want you to give us the last final take home to our delegates and participants, the role of V-PA in current era and in future.
Yes, thank you very much for letting me do that. I think it's V-PA is evolving and promising modality for right ventricular support with or without concomitant respiratory failure. First thing, I mean, it's oxy-LVAD is a promising tool. The current evidence, though, is limited to small retrospective series, and there are no randomized control trials to date. So you have to keep that in mind. But again, the absence of evidence doesn't mean that it doesn't work. V-PA ECMO is a promising form of extracorporeal support for patients with right ventricular dysfunction, and future work should focus on identifying the optimal timing, the cannulation strategy and population for the use of V-PA ECMO. But again, that's the formal answer. The not formal answer is try it, please try it, because you're gonna love it. I mean, I went to V-PA ECMO and I think, wow, it works. I mean, it's amazing. So sometimes you don't have to wait for the big evidence data. I mean, go and try it, and go for a simple patient that is recirculating and you have 82% and you say, okay, I don't like this because if I want to move the patient and he's not doing well with their hunger, please go and try it. And please tell me, feed me back how you do with that. But again, there are not many patients like that, but they're not so scarce. I mean, you will have 1 or 2 patients like that per year at least. So please try, use a cheap cannula and use 2 cannulas. It's much cheaper than a Protect Duo. Of course, marketing issues are going to tell you that the way to do it is with a single lumen cannula, but that's not true. I mean, it's not true at all. In the most experience in Latin America, I told you, it was in Bucaramanga in Colombia. They do a lot of V-PA and they just use 2 cannulas. They don't use Protect Duo. So it's feasible, it's published. Please go for it and try it.
I think we will take your help when we come across such situations and use for a V-PA ECMO needed. And I think next time when we were on discussion, we'll share our experience too on that. Thank you very much, Dr. Rodrigo, being here and sharing your experience and your expertise on that. I thank Dr. Sricharan for bringing that topic, and this has been our 3rd in the series of ECMO programs or ECMO activities, and we keep trying our best to actually bring few more. Thank you all participants, and I conclude the session. Thank you very much, Rodrigo, for your presence and time.
Thank you very much. It's a pleasure for me
enjoyed
to share
your
with you.
presence and your humbleness and the way you explain things. It's been a pleasure to watch you.
Thank you very much, sir. And it's a pleasure for me to be with you again.
Thank you.
Thank you.